that was just what you should do. Would I have time to show this? Bedside management? Yes. So stop injecting, obviously is the first thing. Don't forget you also will affect the brain. 34% of visual impairment to fillers also affect the brain. They get a small stroke. So if we're going to employ sending these people to hospitals, maybe we should send them to stroke units. Involve an ophthalmic surgeon, examine the eye. So you need to check the eye, whether they can see on the other side as well. That's really important to document that because that's what the ophthalmic surgeon works from. And of course, you have to have hyaluronidase in your fridge. There's no point in not. You see, that's our fridge in Dublin, and you can see that it's well stocked with hyaluronic. Use the supraorbital, supratrochlear. Thank you. That's enough.
Thank you so much for your great presentations. Süremiz bitti ama belki bir soru varsa alabiliriz. Buyurun.
Dr. Treacy, thank you for speech. I have two questions for you, clear questions. Is there any interaction between hyaluronidase and the other matrix proteins, except hyaluronic acid?
There's supposed to be, but believe it or not, the feeling is that most of the accidental damage that hyaluronidase does repairs itself within 120 hours. So they feel that in a few days it has restored itself. Now I know that when you go on the internet and you see these people who say, oh look, my face is destroyed with hyaluronidase and that, I've done maybe at this hundreds, if not 1,000 cases, and I've never really witnessed any problems. Now, you'll see on the internet as well where I have cautioned some doctors that they're using too much. Not mention a famous friend of mine in England, our sort of different opinions are up there, but he was advocating people use up to 8 vials, which is like maybe 100,000 units until you get the capillary refill time back to normal. Okay, you got a patient, they've got a vascular occlusion. Capillary refill time is less than 7 seconds, let's say. You want to get it down to 2 seconds. It doesn't have to happen in front of your eyes, as a lot of people think. You say to the patient, listen, we're on a journey together. This is going to take 2 weeks until you're fine. Let me get you out of trouble. I'll give you 1,500 units today, maybe later on another 1,500. I'll do that tomorrow and the next day. I may employ hyperbaric oxygen chambers as well. I'll give you some Cialis. It works as an oral nitrate for 2 days, maybe 3 days. It works at nighttime. I don't like using topical because it can cause syncope, number one, and you're not there in the middle of the night to put it on the patient's face. So I've never really used topical in a long, long time. I just use oral, and there's no point in using Viagra because Viagra only lasts for a couple of hours, whereas Cialis, tadalafil, lasts for a few days. So you've got to have the patient in confidence, and you don't want them running off to the hospital because the chances are that you know an awful lot more about how to treat them than the doctors in the hospital do. Now, if they have to go to the hospital, I have no problem. I'm not saying you shouldn't, but the thing is that if you lose the patient's trust, in other words, you're testing their face and it's still going from 7 seconds to 5 seconds, that's fine. It'll go down to 2. It doesn't have to happen in the first hour, or, you know. And I think that's a mistake that a lot of doctors make, that they think, oh, I can't let you out until the capillary refill time comes back to 2 seconds.
So we shouldn't be afraid of injection?
Nope, absolutely not.
Okay, second question is that, what is your common approach to acute embolism? I mean, the dose regimens and
No,
injections,
somebody has cut you
intervals.
off.
Biz.
I said,
İkinci sorumuz. Daha sonra arada sorarız.
Soruları kahve molasında devam edelim. Uydu sempozyumuyla devam edeceğiz. 11. oturumumuzu kapatıyoruz.